Perfect, I can see it. All right. I just want to say welcome to everyone. We're so glad to have you here. We're so glad to be doing this. I'm Katie Westerneal. I'm one of the board members of the MECP2 Duplication Foundation. I'm joined by Tina Neal, and who's also a board member of the foundation. And we're really pleased to present this inaugural MECP2 Monday webinar. And our first guest, I really have the honor to introduce Dr. Daniel Glaze. He's a pediatric neurologist in Houston, Texas, and he has more than 40 years of experience in the field. He is a professor of pediatrics and neurology at Baylor College of Medicine. He has multiple board certifications and serves as the medical director of the Bluebird Circle Rett Center at Texas Children's Hospital and the Texas Children's Hospital Sleep Clinic. Throughout his career, if you're not familiar with him yet, he's really led the way on research and clinical care for our children. And perhaps most pertinent to today's webinar, he specializes in sleep medicine in children with MECP2 related disorders, including MECP2 duplication syndrome. So on behalf of the MECP2 Duplication Foundation, we are thrilled to have Dr. Glaze here with us today to help our community learn more about sleep. Thank you, Dr. Glaze, and I'll turn it over to you.
Thank you very much. We can have a Texas howdy from our Rett Center in Houston, Texas. We hope, like the Longhorn Steers, that you all are enjoying a beautiful spring day. And just wanted to give you a taste of Texas here with the Longhorn Steers in a field of bluebonnets. We want to thank everyone who's attending, and I must say it's a great honor to be the first to present at these Monday meetings. Can we have the next slide? Again, what I'm going to talk about are sleep problems that we see in MECP2 related disorders. That would include Rett syndrome, primarily seen in girls, boys with MECP2 mutations, and boys with the duplication syndrome. Next slide, please. Perhaps the first question that might be asked is, why are we giving this presentation? What's so important about sleep? And so I wanted to make a few points about why sleep is important to the health of your children and to your family. Next slide. First of all, sleep problems represent a very common problem in all children, but especially in children with neurological problems, with neurodevelopmental problems, like the MECP2 duplication syndrome. It's reported anywhere from 44 to 83% of these children will have sleep problems at one time or many times in their lifetimes. The other point is that these problems aren't just that night. They typically are chronic. They go on and on. And the things that make them chronic and keep them going on include many things seen in the children with MECP2 mutations. Children with neurodevelopmental disorders, children with chronic illnesses, whether it be developmental problems, epilepsy, respiratory problems, or so forth, are at greater risk for having sleep problems and having chronic sleep problems that last not just a few days, but months or even years. In the setting of maternal depression, in the setting of family stress, that also will result in these sleep problems becoming chronic. Next slide, please. Sleep is important for a number of reasons, but the primary thing is the health of individuals, as well as the optimal functioning and development of children as they become teenagers and adults. Poor sleep leads to mood problems, such as irritability. You all may be familiar with that. If you, as a parent, don't get a good night's sleep, the next day you're not the most wonderful person to live with. you often experience irritability. Imagine if this went on for days, for weeks, for months, for years, can lead to significant mood problems. Behavior problems can result from not getting a good night's sleep, poor impulse control, being overactive, cognitive problems, including inattention, learning problems, and especially in the setting of children who begin with neurological problems, the impact on them is going to be multiplied several fold over, and it's even more significant as far as affecting their cognitive function. It's been shown that the rate of accidental injuries is increased in all individuals, children, teenagers, adults who have sleep problems. And again, sleep impacts on all systemic functioning of humans. And so poor sleep can lead to impaired cardiovascular function, poor immunological response, and endocrine dysfunction as well. Next slide. Sleep problems really impact on the family health as well as the health of the child. Sleep problems in a child increase family stress and lead to marital discord. They can decrease effectiveness of parenting. They can lead to poor family sleep, which in turn leads to all the problems we've mentioned, including daytime fatigue, difficulty on the job with job loss. And it has been shown that sleep problems in a child may result in increased incidence of child physical abuse. Next slide. However, there is some good news, and that good news is the pediatric sleep problems are treatable, and the pediatric sleep problems are preventable. And those are some of the things that I hope that you'll get from this talk as it goes on. Next slide, please. One of the first questions that comes up is, how much sleep should my child, my teenager, get? How much sleep should I be getting? And recently, the National Sleep Foundation put together a clever graph showing the requirement for sleep for optimal functioning at various ages. And I think this slide demonstrates several points. One, it does give you an idea of how much sleep is required for optimal daily function. For example, toddlers in the age group of 1 to 2 years require 11 to 14 hours of sleep to maintain their development, to maintain their health, for optimal functioning. The second thing that's emphasized by the slide is that the amount of sleep that is necessary for your health and for your functioning at your best varies depending on age. And it decreases from newborns who may require anywhere from typically 14 to 17 hours to adults, to young adults and older adults who require 7 to 9 hours. To me, this means that sleep is important for development. All the developmental features that happen rapidly in the first few years of life are supported by getting adequate sleep, getting healthy sleep. And the third thing is that I wanted to emphasize from the slide that there is a significant variation in the amount of sleep that what an individual requires. For example, teenagers can require anywhere from 7 to 11 hours, though typically they require 8 to 10 hours for optimal function for their health. So there is some variation in the amount of sleep that is required, and it isn't a one number fits all. Okay, next slide. This slide is what we call a hypnogram, and it shows the progression of sleep stages over a night. And, good. So you start out awake, go to sleep into light stages of what is called non-rapid eye movement sleep. You go into deeper stages of non-rapid eye movement sleep, which tends to be the sleep which is very regular breathing. Everything looks very symmetrical if you're recording the EEG. And then you go back to lighter stages of non-REM sleep. But as time goes on, you begin getting periods of REM sleep, which are in the black here. And as the night goes on, you get longer periods of REM sleep, shorter periods of non-REM sleep, very deep sleep. And towards the end of the night, you primarily get REM sleep. So this is meant to emphasize the components of a good night's sleep. One, it involves timing, by which I mean, when do you achieve sleep? When do you achieve non-REM sleep or very deep sleep? When do you achieve REM sleep? And that time is important, again, for healthy sleep. The amount we've already talked about, again, it varies depending on the age or the age of the child or teenager. Proportion is important, and that's the amount of wakefulness versus non-REM sleep versus REM sleep. In a typical night, teenagers, adults, we as adults, typically get about 25% REM sleep and about 75% non-REM sleep. And that proportion is important because you need to get certain amounts of REM sleep, non-REM sleep to support bodily functions, to support learning, memory functions. And finally, the continuity is important. We all, during the night's sleep, experience anywhere from 5 to 14 arousals. However, they're typically brief. We're able to put ourselves back to sleep. But you could imagine if they were prolonged, if they occurred more frequently, that you'd have a very disrupted sleep pattern, very disrupted sleep, which in turn leads to consequences during the day. And that's what we're talking about. All of these factors are important for obtaining a good night's sleep. And if you don't, the impact is really seen the next day when you have all the problems we've mentioned: mood problems, problems paying attention, problems in a learning situation like at school or in a job situation. You may be sleepy during the day, unable to effectively do your work and to learn. Okay. That's a good night's sleep. Keep that in mind as we go on with the lecture. Next slide, please. A question I'm often asked as a sleep medicine specialist is, how do you evaluate sleep? How do you evaluate sleep problems? How do you learn about them? First of all, we try to identify and characterize what the sleep problem is. So we frequently will take a detailed history of how your child sleeps, when your child sleeps, what happens when they go to bed, what happens as they're trying to go to sleep, what happens during the night, do they awaken, do they experience unusual behaviors, what's the breathing pattern, and so forth. When do they wake up? Do they fall asleep during the day? Are they taking naps during the day? All of those things to understand how they're sleeping, what's going on throughout the 24-hour period in regards to sleep. But it's also important to identify the contributions from medical problems and numerous medical problems experienced by typically developing children, as well as children with neurodevelopmental problems, will contribute an impact on how you sleep. And then I think a very important feature is you need to understand parental attitude and the impact of how their child is sleeping on how they're doing, how they're sleeping, and how they're functioning during the day. Okay, keeping all those things in mind, those are the things that we will explore as we're trying to learn what the sleep problem is that has brought you to the sleep specialist. However, I do want to emphasize, and one point I really want to emphasize in this talk is that you're empowered as parents, as caretakers, guardians of individuals with neurodevelopmental problems, with MECP2 duplication syndrome, to bring to the attention of their primary care physicians, their pediatricians, their internists, that they're not sleeping well, that they are experiencing sleep problems. And I think that's very important because sometimes a primary care physician who is seeing 40, 50, 60 patients a day has a little time to make, to ask questions about sleep, to explore sleep. But I think it's very important you bring it to their attention and that those problems have a chance to be explored, to take time to explore that. Next slide, please. Again, an important thing that we do, we not only evaluate what the sleep problem is, but what are the medical problems that might contribute to the sleeping issues. And some of these problems occur actually more frequently at night, or more of a problem at night during the period that you typically are asleep. Such problems of seizures may occur more frequently as you go to sleep or come out of sleep. GI problems, including gastroesophageal reflux, may be more prominent or more of a problem in relationship to sleep. Medications impact on how you sleep, either causing you to be sleepy or might even cause you not to be able to sleep and to have problems with what is called insomnia. And it's important to know what medications an individual's on and understand how they might be impacting on the quality of sleep. Equally important is to understand what behavioral problems paying attention, what if there are psychiatric problems, mood disorders occurring during the day, but which can contribute to problems with going to sleep, with maintaining sleep. One of the things I didn't put down here, which was brought up in some of the questions that I was provided, were the question about motor problems, spasticity, and other motor problems, including cramping and possibly so-called growing pains. I think, again, individuals with neurodevelopmental problems, neurological problems, may also experience motor problems such as increased tone, rigidity, those types of problems, which may contribute to sleep problems, contribute to a poor night's sleep, and which have to be addressed in themselves. So they would be included in this list, and I will talk more about the subject of growing pains in children and adolescents. Next slide, please. We have a number of tools that when we evaluate individuals for sleep problems, some of these tools are available to your pediatrician, your primary care physician, in addition to the sleep medicine specialist. One set of tools is in regards to questionnaires that have been validated, standardized, proven to be effective in identifying sleep problems. A very simple questionnaire shown on this slide is referred to as the BEARS. And this is something that can be used by pediatricians. It asks 5 questions, which often are answered by proxy by the parents rather than the child, but can be answered by the child also. These include B, for bedtime problems, problems initiating sleep. What's the character of the bedtime routine, the environment of the bedroom? How does that impact on the kid's ability to go to sleep? E is for excessive daytime sleepiness. Is the child having difficulty waking up in the morning, having difficulty falling asleep at school, falling asleep while doing school online? We know that children do nap up to about age 5 to 6 years, but children taking naps after that age, after 6 to 7 years, are children who are excessively sleepy and who should be investigated why they are sleepy. So taking naps after that age, it should raise a flag that something's going on. Frequently, it's a problem with not getting sufficient sleep, adequate sleep at night, resulting in daytime sleepiness. A is for awakenings that occur during the night, and we're dealing primarily with awakenings that cause problems, that cause parent intervention, that are occurring frequently with difficulty for the child to put themselves back to sleep and every night or many nights a week. R is for how regular is the schedule, how regular and what is the duration of the sleep period. And finally, S, is there a history of snoring, along with like a history of pauses and breathing during sleep. If you answered, I would think, 2 or more of these questions with positive, with a yes, then I think that bears or is an indication that further investigations need to be done. Other tools we have shown here, this is what we call a sleep diary. And what we have typically is have the parents fill out for every 24-hour period for a 2-week time when the child is awake, doing the X's. I mean, when is the child asleep, shown by the X's. When is the child awake? When does the child go to bed? When is the child asleep again? When we do that for the 2-week period, it gives us a good idea of how regular the sleep pattern is, but gives us some idea of, is there a problem going on? Just for instance, this child has a very good bedtime, reportedly, this teenage child, but actually doesn't go to sleep until 2 or 3 hours after they're put to bed. This is late in their sleep phase. And this is a problem because, as with most adolescents and teenagers, they typically have to get up early to go to school. And that means that they don't get the full amount of sleep they're going to require. And they tend to be sleepy during the day. And indeed, on weekends, they tend to sleep in, and you can see they're even sleeping during the daytime period, napping then. So the sleep diary, when filled out properly, can be very helpful in knowing the character of the sleep pattern, giving us some idea of what is going on with sleep, what might the problem be. If there are frequent arousals, we suspect something going on during sleep, like sleep disordered breathing. Sleep apnea might be causing the arousals. So this is a valuable tool that can be easily filled out over a 2-week period, gives us important information. This young man is wearing a watch. This is like the Fitbit that you all can go to your local Target or Walgreens and buy. It's called an actigraph. It actually it's battery operated and records if you're active, by which I mean there's movement, like you'd be moving your arm here, or no activity. So there's no movement of the arms or the extremities. And the paradigm is this information then can be put in a computer and you can get information as to whether the patient is asleep, by which we mean there's little or no movement, or awake, there's a lot of movement going on. And like the sleep calendar, this tracks over several days or even over a week's time, the sleep pattern, the wake sleep pattern that a child has, and determines, is that child sleepy during the day? Is that child getting a good night's sleep? So these are some of the tools that we have available to evaluate your child's sleep, how they're doing. They're non-invasive, they're easily done and provide important information to the quality and character of sleep and help us identify, is there a sleep problem going on? Next slide. This slide is to illustrate what is called our gold standard, namely polysomnography or a sleep study. This is a very powerful tool for a number of reasons. One, we do this in the laboratory It is recorded from the time you're put to bed to the time you get up, so over the whole night. So it's a long time, lots of information. And that information includes many parameters, including brain activity, EEG, including breathing, the flow through the nose and mouth, movement of the chest and abdomen when you're breathing, the oxygen values by a sensor that's often put on the finger or the toe, the waste gas called carbon dioxide, which is breathed out, and the sensor picks up the amount of waste gas that you're breathing, movements of the extremities, and often it's filmed so that we can go back and look at specific times, specific behaviors, and relate them to all of these things going on. And so this records all of these parameters at the same time, continuously, during the time you undergo a sleep study. The next thing is that it's non-invasive. There are no needles, nothing that is hurtful in any way. It's sometimes somewhat difficult for children, especially children with developmental problems, to tolerate the placement of the sensors, but most frequently we're able to complete the study and get adequate information, important information, as to the exact character of the sleep problem, whether that be abnormal EEG activity, such as in the seizure, abnormal breathing, such as in sleep apnea or obstructive sleep apnea, abnormal movements of the legs, such as an entity called periodic limb movements, and put it all together and give us a good idea of what the character of sleep, what the problems are that are occurring during sleep. Next slide, please. Currently, there are many indications for doing a sleep study. When we suspect there are breathing problems, this is OSA or obstructive sleep apnea, or central sleep apnea, CSA, where there are breathing problems, this study is done in order to characterize the breathing problem and determine the severity of the breathing problem. It also can be done to treat the breathing problem with something called CPAP. This is the mask that you wear, delivers pressure to keep the airway open during sleep. And we actually evaluate CPAP during sleep study to see how much pressure it takes to resolve the breathing issues. We do this study in children who are experiencing daytime sleepiness. We'll do an overnight study to see if there are any factors that would give rise to a poor night's sleep. And then we do a daytime study and we see, is the child falling asleep during the day? What type of sleep do they fall into? For example, people with narcolepsy often go into rapid eye movement sleep or so-called dream sleep during the daytime. Those without this disorder, typically developing individuals, do not experience rapid eye movement sleep during the day. We do the study if there are unusual behaviors that happen at night. For example, in individuals who are susceptible or at risk for having seizures, if they're doing recurrent behaviors such as stereotype and character, which might represent seizures, behaviors which are resulting in injury. We will do the sleep study, actually record the behaviors, relate them to other physiological parameters, as I said, including the EEG, breathing, and so forth, determine the exact character. Are they seizures or not? Are they some other type of sleep behavior that is not seizure in character? PLMs refers to periodic limb movements. If we hear a history of restlessness, recurrent leg movements, arm movements that are going on throughout the night, we will do the sleep study to see if we can record these type of movements and see if that's the problem. So these are some of the reasons that we actually do a sleep study, but we have been using a sleep study in research. We're currently doing research in individuals with the duplication syndrome as well as boys with MECP2 mutations. And again, the sleep study is a powerful tool that provides a lot of information over a long period of time regarding lots of parameters, including brain activity, breathing, heart rate, and so forth. Next slide, please. I thought I'd just review some of the typical sleep problems we see in children as well as adults. Insomnia, we typically think of children, we think of, insomnia, we typically think of adults who have difficulty going to sleep, staying asleep. But this is a problem that can be frequently seen in children, especially in children with developmental disorders, such as autism, such as duplication syndrome, such as Rett syndrome. Insomnia refers to having difficulty initiating sleep, difficulty going to sleep, or difficulty maintaining sleep, so frequent awakenings, or experiencing early morning awakenings that result in getting inadequate sleep at night. And essentially the complaint often is non-restorative, non-restful type sleep. So insomnia is a frequent problem seen in children with MECP2 mutations and frequently has to be addressed. Next slide. Many children with MECP2 mutations have wake-sleep scheduling. They not only have difficulty going to sleep, maintaining sleep, sleeping less than typically developing children at night, but they may be sleepy during the day, and it's like their schedule, their 24-hour schedule is off in comparison to what we would expect that to be, what we accept as being more normal schedule. So they have delayed sleep onset, early morning awakenings, a regular sleep schedule. And this problem I frequently see in children, adolescents, adults with MECP2 mutations such as duplication syndrome, Rett syndrome, and so forth. Next slide. Other common problems include sleep disordered breathing. And within that category, we include obstructive sleep apnea. Obstructive sleep apnea means that you have effort, but you're not moving the air in and out. And there's something causing impairment of moving the air into your lungs, obstructing that movement. This is in contrast to central sleep apnea, where there is no effort and no airflow, no movement of air in and out. Children with MECP2 mutations, with duplication syndrome, males with MECP2 mutations, as well as girls with Rett syndrome, can and do experience both types of these breathing disorders. And they occur frequently, even more frequently, in these children, in these adolescents, than in typically developing children. Children with MECP2 mutations may experience parasomnias. These are unusual behaviors which occur in relationship to sleep. And they may just be sleep awakening where the child, adolescent appears confused and isn't fully awake, to more dramatic episodes of night terrors where the child seems to arouse but doesn't get fully awake, is screaming, is very agitated, has a rapid heart rate, and to other behaviors that will occur in relationship to sleep, which seem to be unusual or out of the ordinary, but maybe not harmful to the child, but disrupting of sleep. Periodic limb movements we've talked about already can occur in children with MECP2 disorders. A moment I'd like to talk about growing pains. Growing pains refers to really a symptom and doesn't refer to a specific disorder or specific cause. And that symptom is the complaint of discomfort typically involving the calf muscles, the lower extremities, but can involve the upper extremities too. It is characterized by occurrence in children and adolescents, typically in 2 periods between the ages of 3 to 5 years, or between the ages of 8 to 13 years. It's reported to occur as many as 40% of children, and is characterized by this feeling of pain or discomfort in their legs, often resolves with movement, with massage of the muscles, but leads to disruption of the sleep pattern and not getting good night's sleep. Recent information and concern about growing pains has been around an entity called restless leg syndrome. This is a disorder associated with periodic limb movements, but characterized by feelings of discomfort in the legs, the need to move, to walk, the occurrence as you're going to sleep during the night or when you're at rest. And this sounds very similar to growing pains. And it may be that a number of individuals with growing pains actually have restless leg syndrome. The importance of this is it has been associated, restless leg syndrome has been associated with iron abnormalities, with low levels of a substance called ferritin, which is responsible for getting the iron to your brain, to carrying a neurotransmitter, to helping with the metabolism of a neurotransmitter called dopamine. And lack of that ferritin, low ferritin levels, and it results in iron dysfunction, results in dopamine dysfunction, and can result in the problems that were described that happened in restless leg syndrome. So if your child is experiencing, indeed, restlessness during sleep, moving about during sleep, complaining of discomfort, pain in their extremities, especially as they go to sleep or during the night, seems to have growing pains, they may have restless leg syndrome, and checking the iron levels, the ferritin levels, may be helpful in determining the actual cause and a potential treatment. By giving supplemental iron, you can often resolve this issue. So that's my story about growing pains and the interest in its relationship to sleep problems. Okay, next slide. I thought I would review what we've learned from a number of studies concerning sleep in disorders of MECP2 mutations. First of all, the natural history study has primarily involved girls and women with Rett syndrome. And we asked a number of questions about how they were sleeping and have learned that sleep problems occur frequently in these individuals. Next slide. More than 80% report sleep problems. So sleep problems are frequent in girls with Rett syndrome. Many of them have problems going to sleep, have difficulty with frequent awakenings, difficulty with waking up throughout the night and waking up early. So a significant number of individuals with Rett syndrome experience insomnia. Further studies indicated that the incidence of sleep disordered breathing, obstructive sleep apnea, was increased several-fold over the general population. Instead of being 1 to 2%, which we find in the general population, it was more like 10 to 20% of individuals with Rett syndrome have obstructive sleep apnea and should be screened and questioned when they're evaluated for this disorder. They also experience, especially as they become teenagers, problems with daytime sleepiness and sleep-wake scheduling problems. Next slide, please. We also have administered a questionnaire called the Child Sleep Habits Questionnaire to boys with the MECP2 Duplication Syndrome. On this questionnaire, a score greater than 41 indicates significant sleep problems. And overall, we found in this group of boys and young adults with the duplication syndrome that 60% experienced some type of sleep problems. This occurred equally in young as well as the older group. Next slide, please. In 43%, they had symptoms, namely problems initiating, maintaining sleep at night, as well as early morning awakenings. As many as 43%. 30% experienced sleep disordered breathing, obstructive sleep apnea. 50% experienced these unusual behaviors during sleep, which were disruptive of sleep and disruptive of sleep of the family. And about a third were experiencing daytime sleepiness. And the small number of males with duplication syndrome who we administered this questionnaire to. Next slide. As I said, we've been doing a research study where we've been recording the sleep study, the overnight sleep study, in males with the MECP2 duplication syndrome. And this represents information from 16 males, ages 2 years to 22 years. In almost all of them, they experienced some degree of sleep disordered breathing from mild to severe type. This was typically obstructive sleep apnea, not central sleep apnea. And it seemed to worsen as these boys became adolescents, teenagers, young adults. We found that the total sleep time was reduced and the REM sleep percentage was reduced also. The importance of this, go back to the earlier slides, we need the sleep, and the reason we have a lot of sleep when we're very young, it supports development, it supports learning, it supports memory. So you could imagine not getting adequate sleep will impact on learning, will impact on cognitive function, ability to be alert, and to be engaged in various therapies. A number of these boys and adolescents experience periodic leg movements, repetitive leg movements during sleep, which were disruptive and led to arousals. We found that after age 3 years of age, all of them had abnormal EEGs, and several of them had seizures in addition to the EEG abnormalities. All the patients that we studied did snore, and which would be a sign that they might be experiencing sleep disordered breathing. And many of them were sleepy during the day. Those are the types of problems that we identified by actually doing sleep studies in these males with duplication syndrome. Next slide, please. In contrast, a few patients, 6 patients, are males with the MECP2 mutation. They aged and ranged from 6 to 18 years. There were 2 patterns of disordered breathing. The very young children, around 6 to 7 years of age, had both wake and sleep breathing abnormalities. So when they were awake and sleep, they had abnormal breathing patterns characterized by recurrent central pauses, during which time they had no effort and no airflow. And they had a pattern called periodic, meaning that they would have this central apnea, take a few good breaths, then another central apnea, and so forth. In contrast, the older individuals, the teenagers with MECP2 mutations, the boys with MECP2 mutations, experience obstructive sleep apnea and not central sleep apnea. Like the males with duplication syndrome, all of them had reduced total sleep time, reduced amounts of REM sleep, and all of them had abnormal EEGs. Many of them had discharges associated with seizures, and some of them we actually recorded seizures. So these are the typical findings from doing overnight sleep studies in males with MECP2 mutations. Next slide, please. So I thought I would just show you what we actually record during a sleep study. In this slide, it shows the EEG pattern here. It shows the breathing pattern here, including effort and airflow. And what you see is this is a typically developing teenager. Breathing is regular, constant. There are no pauses here. This is during N2, what we call non-REM sleep, stage 2. You can see that the oxygen values are in a normal range, 98, 99%. The carbon dioxide, the waste gas, is typically in the range of 45, 46. So these are what normal breathing in a typically developing teenager looks like. Next slide, please. This happens to be a 14-year-old with MECP2 mutation, a boy with MECP2 mutation, so a teenager. And this one does show a continuous pattern of breathing here. But the one thing you notice is these are the waste gas, carbon dioxide. They're very much elevated in 60. Below 50 would be normal. This is indicative of what we call hypoventilation, that there's breathing impairment to blow off or get rid of the waste gas. And this can be detrimental to the function of the heart and to the lungs. And so this is a teenager who was having hypoventilation, elevated carbon dioxide values. At other times also was having pauses, which were obstructed pauses where there was continuous effort, but no airflow as measured at the nose here and at the mouth here. So this is what we recorded in teenage boys with MECP2 mutations. Next slide, please. This is a young 6-year-old boy with a MECP2 mutation. This is the individual awake, and what you can see is effective breathing here, no effort here, no flow here, central respiratory pause, effective breathing here, no effort, no airflow going on here, effort being done, then again repeats a central pause. And this goes on, this is the periodic pattern. During this time, the waste gas carbon dioxide is only minimally elevated. The oxygen values are okay. Next slide, please. On the other hand, this is during non-REM sleep, and it's the same type of pattern. Pause, breathe, recurrent like this. This is how this 6-year-old boy was breathing throughout the night. And again, there are some drops in oxygen values below 90%, which is our cutoff for being normal. The carbon dioxide values are again elevated above 50. So this is an abnormal breathing pattern, which is not a healthy breathing pattern, which can be detrimental to the functioning of the heart, to the functioning of the lungs. Again, there are some males with the MECP2 mutation who actually require being placed on a ventilator because of this type of breathing pattern. So this is what we actually do record during a sleep study, just to give you an idea of what it might look like. Next slide, please. So I'd like to go on about what we do to manage sleep problems. First of all, if we identify medical problems, for example, seizures, or we identify that there's increased tone, spasticity, rigidity going on, those issues need to be addressed with appropriate therapies, whether it be medication, physical therapy, exercising, massage therapy, something like that. Then manage daytime behaviors where there are significant behavior problems, mood problems. Those need to be addressed in order to identify, to address the nighttime problems and to have an opportunity to correct the nighttime difficulties going to sleep and maintaining sleep. We look at the medications. For example, is the boy on a lot of medications for seizures? Could they be causing the daytime sleepiness? They need to be adjusted. Or are there certain medications, for example, medications that are used to treat behaviors such as Prozac, which actually cause insomnia, especially when they're given at night. So we check out, are the medications themselves causing problems with sleep, causing the child to be sleepy or be unable to go to sleep. We'd like to provide to the family information about how a child to sleep, scheduling of child, what represents healthy sleep, and then set some goals which are achievable and which will help the family as well as the child with the MECP2 mutation. And finally, we do treat sleep problems, and we'll talk about some ways to address those sleep problems. Next slide. In general, I try to outline some good habits which maintain good sleep hygiene. And these things include making sure that your child, your adolescent teenager, has time enough to get the age-appropriate amount of sleep that they need to get. So the schedule has to take that into mind. So if they're having to go to school early in the morning, they need to have adequate sleep at night to be at their best to function during the time they're at school. We suggest that prior to going to sleep, you set a bedtime, and then 20 to 30 minutes before that, you have a routine that doesn't vary from night to night, which prepares the individual for sleep. Excuse me. Dr. Glaze apologizes for his phone there. Okay. That routine, you want to put the child ready to go to sleep, not asleep when you go to bed, so that they learn how to put themselves to sleep. And they identify this, the routine, as it's time to do that. Again, regular bedtimes, if they're taking naps, schedule those. So it's the whole 24-hour period. The best would be a dark, cool room that's safe for your child. Then we would allow a pre-bedtime meal, small snack. We try to avoid any caffeine in drinks, alcohol. Remember, many medications that you take contain some degree of alcohol. We avoid those things. We suggest that routine exercise be done several hours prior to go to bed. Actually, exercising doesn't put you to sleep. It actually promotes being awake and keeps you awake. But done several hours before your bedtime, it will help you go to sleep and will lead to a better night's sleep. And you can use light as your friend. Bright light exposure in the morning. So turning on all the lights, exposure to bright sunlight in the morning promotes an earlier bedtime onset of sleep. And then if you want to delay that, you give bright light in the evening, several hours before you would like your child or adolescent to go to sleep. So light can help set the schedule. Next slide, please. There are several behavioral techniques that can be used to extinguish unwanted behaviors, such as resistance to go to sleep at night, awakenings at night, and these include extinction, where you either delay any response to the child who's crying, or delay your response by a set amount of minutes and then go in to check on them, make sure things are going okay. Relaxation therapy, we frequently use massage therapy, weighted blankets. All these things can be helpful in the child being able to maintain sleep. In certain situations, we will use medications. We often will combine these behavioral techniques with medications. Next slide, please. Listed some medications that we frequently prescribe, especially for children with developmental problems, neurodevelopmental problems, where behavior techniques are less effective or more difficult to institute. There are no approved medications for inducing sleep as sleep hypnotics for children, for adolescents. So we have to use some medications that may be used in adults or which are used for other reasons, but their side effect is to make the individual sleepy. These include clonidine, zolpidem, which is a hypnotic ambient, certain antidepressants such as trazodone, other antidepressants such as Zoloft may be helpful given at night in helping the child to sleep. I'm going to come back to melatonin in just a moment. Risperidone, often used where there are adverse behaviors, self-abusive behaviors. When given at night, it often helps the child initiate and maintain sleep. Certain anti-epileptic drugs, AEDs, which are used for seizures, can be helpful because of their side effect in making you sleepy. One of these is called gabapentin or Neurontin. When given as a single dose at night, 15 to 20 minutes before going to bed, it often can help initiate and maintain sleep. Melatonin, which is a medication you can get at your local Walgreens supermarket and so forth, and you don't have to get by prescription, comes in liquid form, comes in immediate acting form as well as delayed action onset and delayed action form, has proven very useful in children with neurodevelopmental disorders. They indeed may have an underlying abnormality in melatonin metabolism, and additional melatonin can be helpful in initiating and may even help maintain sleep for a time. However, what we found is a small dose, more in the terms of 1 to 5 milligrams, is quite effective. And larger doses, 10 or milligrams or higher, typically are not needed. What I find with melatonin often, of course, is initially very effective, but sometimes a drug holiday, stopping the medication for a while will result again in it being helpful and giving the desired effect of helpful in initiating sleep, maintaining sleep. In my experience, the CR, the continuous release form, has not been more helpful than the regular form of melatonin. However, there have been reports that the continuous release form can be helpful in certain individuals, especially those with neurodevelopmental problems. The one thing I say about melatonin, make sure when you buy it over the counter that you get melatonin. Sometimes melatonin is combined with other natural agents like valerian and so forth, or even like Benadryl or something like that. I think what you want to get is pure melatonin. Make sure that's what you're getting. I have no evidence that medications such as these natural agents like valerian will actually be helpful for sleep in children and may even have side effects. Some of these agents will actually worsen seizures, especially in this group of patients who are at risk for having seizures. So these are some of the medications that your pediatrician, that your neurologist, or that your sleep medicine specialist may choose from to help with sleep, and often will combine it with behavioral techniques. Next slide. Just some further information about nighttime awakenings. They're of concern when they are more than 3 to 4 per night. As I said, most of us experience a number of awakenings or arousals at night, but the thing is we have learned to put ourselves back to sleep. And the problem in many children, especially children with developmental disorders, is they've not been able to learn that, and that the awakenings become prolonged because they've not learned the way to put themselves back to sleep, and they remain awake and they require intervention of their parents. So concern if they're frequent, more than 3 to 4 per night, if they're long, more than 20 minutes, if they require parental intervention, if they're associated with snoring, movement injury, unusual behaviors, those should indicate to you that they might represent a significant sleep problem, and they should be reported and addressed with your primary care physician, pediatrician, neurologist, and maybe even a sleep medicine specialist. And if the child is experiencing daytime sleepiness beyond just the usual routine of taking naps, or as an older adolescent teenager who's sleeping during the day, those problems need to be addressed, be reported to your pediatrician, internist, and possibly require the intervention of a sleep medicine specialist. Next slide, please. For management of sleep disordered breathing, we have several approaches. Primary approach, again, is tonsillectomy and adenoidectomy, TNA. So in young children, the tonsils, adenoids may be enlarged, frequently are enlarged, may cause blockage of the airway passages, lead to obstructive sleep apnea. And so the TNA can be a cure for this problem. However, in children who have developmental disorders, who have neurological problems, they may also have muscle tone issues, either increased tone, hypertonia, spasticity, or decreased tone, hypotonia, laxity, or relaxed muscles. That can lead to problems with keeping the airway open or the airway constricted too much, and they are at risk for obstructive sleep apnea. So other means beyond doing the tonsillectomy may be appropriate. These include CPAP, the mask that's worn that delivers pressure to keep the airway open. Some children experience the problem more frequently when they're on their back, so side sleeping position. For some children, raising the head of the bed, elevating the head of the bed may resolve the issue. Certainly during the first year of life or during the first 6 months of life, we'd like children to be put to bed to sleep on their back. After a year, sleeping on the side or different position from supine sleeping position would be allowable. I think if the child has significant muscle problems, control of muscles, inability to raise their head, to turn over, then care has to be exercised in putting them on pillows, underneath blankets where they, or bed clothing of that type, where they might have problems and getting out of positions that could be harmful to them. Again, children as well as adults are at risk for developing obesity, and weight management becomes a significant component, but not the only component frequently of managing sleep disordered breathing. Medications such as caffeine and those medications to stimulate breathing are used in newborns, but I really personally don't have medications that can be effective in treating sleep disordered breathing, obstructive sleep apnea in older children, in adolescents or teenagers. Next slide, please. Thank you. For wake sleep problems, again, maintaining a strict 24-hour schedule that will be predictable as far as when you go to bed, when you get out of bed, even when you eat or don't eat, when you're exercising, when you're doing your therapies, when you're doing your educational program, is helpful in promoting proper sleep-wake habits and scheduling. Again, using light therapy to promote the schedule, early morning light to promote an earlier bedtime, late evening light exposure to promote a later bedtime can be used. And melatonin can be used in two ways: as a hypnotic, given 15 to 20, 30 minutes before you go to bed, or as a clock resetting medication. Melatonin given in doses of 1 to 3 milligrams, 3 to 4 hours before you go to, the planned sleep time that you would like the child to have, can be helpful in resetting the clock so the child is able to actually go to sleep at that time rather than at a later time, and avoid having a delay in their sleep phase. Next slide, please. So my final slide is just to come back to the commercial for this whole presentation. Good night's sleep improves daytime alertness, daytime behavior and mood. It also impacts favorably on functioning of all bodily systems: cardiovascular, immunological, endocrine. It makes for a healthier child, healthier teenager, healthier adult. And indeed, healthy sleep in children will lead to improved quality of life for the family, a healthier life for us as parents. So to all, a good night's sleep, and for your children, also good night's sleep. And that's going to end this talk. Thank you.
Thank you so much. We have, this was really wonderful. I learned so much. And we have some questions in the Q&A. So our first question: does the total hours of sleep, going back to that graphic that you showed, does that include naps, or does that have to be all in one setting?
No, that includes naps, so it doesn't have to be in all one setting.
Okay, so like for my age son, like 10 hours, he can have a 2-hour nap and then have 8 hours.
Yeah, it includes that time.
Okay.
Exactly.
Okay, perfect. And then we have a question: how can one distinguish, how do you tell the difference between sleepiness after a bad night of disturbed sleep and then the sleeping off that happens after a seizure?
So actually, both may be playing a role. A bad night's sleep may actually make it more likely that you have a seizure. And seizures can occur in relationship to going to sleep, waking up from sleep, getting sleepy during the day, and occur very frequently at night in relationship to what happens at night. So both may be playing a role, and it's maybe difficult to sort them both out. So I want to go back to what I said about management. The seizures have to be managed under good control. You want to make sure that the medications themselves aren't leading to sleepiness during the day. Then you have to go back to what's going on during the night. Indeed, it may be helpful to do the sleep study to see, is the individual having seizures at night, disrupting sleep, or because they're having sleep apnea, they're more prone to be having seizures or more prone to have a disrupted sleep. There have been reports that addressing the issue of sleep disordered breathing by doing tonsillectomy not only impacted favorably on sleep disordered breathing, so you breathe better during sleep, but it reduced the occurrence of seizures and was helpful for management of seizures. So it's a two-way road and isn't one exclusive of the other.
Thank you. Great. Here's one more question. Have there been any successful treatments for seizures caused by the arousal phase of sleeping?
I'm sorry, could you repeat that?
Sure. Have there been any successful treatments for seizures that are caused by that arousal phase of sleeping? So I think those seizures that happen during that phase.
So again, I want to make the point that arousals from sleep don't cause the seizure. It's like often when your children are sick and have fever, they're more likely to have a seizure. It's not the fever per se causing the seizure, it's the underlying neurological problem, in this case, the duplication syndrome. That's the cause of the seizure. So medications that are used to treat seizures during the day can be effective for seizures that occur at night. And by management of that, by controlling the seizures, will lead to a better night's sleep. So we use the same medications, and they've been shown to be effective for seizures occurring during the day or at night.
All right. And we have one more. Will therapies like speech, PT, OT, does that increase the need for sleep in our children?
Yes, because you need to get proper amounts of sleep in the right proportion. One, to be at your fullest alertness, not to be sleepy during those therapies, not to be moody during those therapies. You know, if you haven't had a good night's sleep, you don't want to be bothered no matter what. Number two, again, sleep is important, both non-REM, non-rapid eye movement sleep, and rapid eye movement sleep for preserving and learning what you've learned during the day. If you don't get a good night's sleep, you're not going to be able to be effective in what you've learned during the day or the next day. So it is important.
That wasn't my question, but it could have been my question because I find that there is a relationship for my son with MECP2 duplication syndrome between, you know, if he had a big day of therapy where he had a lot of therapies, he's a lot more tired and he is, you know, he does need more sleep that day. He'll take a better nap that day than on the days when either he doesn't have therapy or he only has maybe one of those. So that's really interesting. And then we have a question, are there medications for arousals?
So it's very interesting that that's mentioned. There is a new medication that's just been released, that has been released in European countries called pitolisant. And actually this medicine doesn't induce sleep. It actually causes you to be awake and alert and is given in the morning rather than at night. And giving it in the morning for certain disorders like narcolepsy keeps you awake. And so it may be helpful in those children who have sleep-wake scheduling problems that are sleepy during the day. It may be a medicine that we can use for them. And it's being studied at this time in this country for that possibility. So that's an interesting question to go the other way. You know, do we have medicines to keep you awake? Yeah.
That's a really good question. Thank you to everybody who submitted the questions, and thank you, Dr. Glaze, for answering them. We really appreciate it. Everybody can see on the screen that we are at MECP2D.org. If you would like more, this is part of our family support, and if you want to connect with a representative or you want to find our guides, we have parent guides and physician guides. And then as this series goes forward, we would love to hear from more families about who you'd like to see on future webinars. So I do want to say to Dr. Glaze, thank you so much. And thanks to everybody in attendance. This was wonderful.
Thank you all. It's an honor to be the first Monday. Thank you again.
Wonderful. All right. Bye, everyone.
Bye-bye.